So we continue now with the rehabilitation field, but this time over teeth. And we go back to Spain to meet our dear friend Jon Gurrea. Jon is an extraordinary practitioner and international speaker. After his studies in Spain, he followed a post-graduation course in the United States at the NYU College of Dentistry. He has been lecturing in many courses on the topics of bonded porcelain restorations and comprehensive care, alone or side by side with some of the world top lecturers such as Auguste Bruguera. We are very happy to be able to watch his lecture about the technical details regarding tooth preparation for indirect restorations. Let's hear the Spanish from Bilbao, my dear friend Jon Gurrea. I hope you enjoy.
Hi everyone around the world and welcome to International Aesthetic Masters. My name is Jon Gurrea from Bilbao, Spain, and today my topic is what do I have in mind when I have to prepare teeth for indirect bonded restorations? And well, it's very common when we talk about conservative dentistry and aesthetic dentistry to think for the less invasive to the more invasive treatments. Of course, the less invasive is no treatment. Some people just don't know what they want, but at the end, maybe they don't need anything to improve their aesthetics. And of course, then an easy step is just doing bleaching, or with bleaching and a little bit of direct bonding, we can have fantastic results. But sometimes we have to break some eggs to do the omelette, and indirect bonding and prepping teeth is needed. Not all the times we have to prepare teeth, but sometimes we do have it. Of course, one fantastic and very conservative way of improving the aesthetics in some patients, in some cases, is orthodontics. And orthodontics is a very important part of every restorative practice who wants to really do aesthetic dentistry. But my topic today is going to be indirect bonding, as more especially the preparations. And as you can see, I haven't said anything about minimally invasive, because minimally invasive doesn't really mean anything. It only means that we're going to do the less invasive procedures to achieve the goals that both the patient and the clinician desire. Therefore, any treatment can be minimally invasive. It only depends on whether it is indicated or not. For example, if we have to do, let's say, a bridge, and or placing an implant, and the teeth that are going to be the abutments of the bridge are sound teeth with no decay, no fillings, no crowns, probably the less invasive procedure is going to be the implant. And even if it needs a, let's say, sinus elevation, it'll probably be better to do the sinus elevation and the implant. So it would be minimally invasive. There's not a list of minimally invasive treatments. We have to think about the goals of our patient and of our practice to think about minimally invasive. So today I'm going to talk about the preparations and which is the purpose of the preparation. What do we have in mind? What do we look for? Where? We have three situations. We have to think about three things. Which is the insertion path? Do we have enough prosthetic space? Because maybe we have a dark substrate or a malposition, and we have different insertion paths and different prosthetic space requirement. And of course, we want to ease the impression. It is important to think about the impression, because if we want to send info to our technician, the best info is a good impression. If we don't make a good impression, even if we prepare beautifully, it doesn't mean anything. The technician is not going to have the information. So, if we were planning a play during a game, we need to think about certain aspects, and here is pretty much the same. As we have to prep or not prep? If we have to prep, how much do we have to prep? And where do we leave the margin? Those are the big questions. Those are the things I think when I'm holding the handpiece and we take the burr to start preparing teeth or treating a case for veneers. So the first question is to prepare or not to prepare. Well, for me, the only thing that matters is the insertion path. If we do have an insertion path, everything is going to be fine. If we don't have it, we have to make it. That's the first reason why we want to prepare teeth. So let's see this case. This patient said, I don't like the black triangles in my smile. Well, I was not really bothered about this. I told him, look, with just a little bit of direct bonding would be fine. Let's say a few composite resin restorations in the laterals and centrals just to close that black triangle and between the centrals, and that would be enough. But the patient wanted also to change a little bit the incisal edge, and he was interested in doing ceramics because somebody told him that I was doing veneers very well. So I said, well, I think it's going to be better to do just composite resin. But the patient didn't want it to. And he also wanted me to be very, very conservative. At this point, I did a mock-up and I told him maybe I have to prep a little bit those teeth. He said, well, if you have to do it, just do the minimum. And when we have to think about prepping or not prepping, I committed a mistake here. Because if we have a triangular tooth and we have the papillae where the arrows are, I usually, if I want to close the black triangle, what will happen is that I have to make space and introduce the veneer, the indirect restoration, in those black triangles. And the insertion path is going to be complex if we don't prep on the sides of those arrows. We have a square tooth and we have full papillae. What will happen is that usually we don't have many problems, and maybe just a very little reshaping will be enough. So we can say that this is optional. You can prep or almost don't prep. The only cases where not prepping at all is possible are when we have rounded teeth, or when we have teeth where the interproximal area is wider than the incisal edge. In these situations, just the insertion path is easy and we can go no prep if we want to. Of course, the teeth have profile. And if we have a normal tooth and we want to cover the incisal edge and we don't want to prep, what will happen is that we will have a stop here. So our restoration will be partial restoration. We will not cover the whole facial aspect of the tooth. If we have a more flattened surface, this flat surface, and we want to cover the incisal edge again, we will be able to almost cover all the facial aspect or totally. And if we have a very curvy tooth, for example, let's say a canine, this will happen. The stop will be here, so the restoration will be partial and will be clearly partial. So with the previous patient, I tried to soften all the curvatures and make a flatter tooth, and this is what I had. But I was not that flat. I was very, very conservative. And, you know, if you go really thin and you have no insertion path, and this is what happened. I thought I had it, but I didn't have it. This can happen. And this is a very common mistake. We don't really see all the curvatures of the teeth when we're preparing. So what I had to do at the end is re-preparing a little bit more, I actually had to do a small margin, and as you can see here, this is the margin, and prepare a little bit more and give veneers to our patient. And well, I can say this is not my best case. Veneers were not indicated here, and I still think that composite resin and bleaching would have been more than enough. Anyway, the patient was really happy, but I can tell you this was a mistake, and everybody learns a lot from mistakes. If you want to not prep at all, you have to have teeth like this. This is the real good situation. The previous one was triangular tooth. In here, in this case, what we have is wider teeth in the interproximal, where the papillae are, than in the incisal edge. So an insertion from incisal to apical is easy. We already have it. There's no big deal here. We don't have to prep at all. So preparation is not a good idea. If we have a occlusal view, you can see very flat teeth. So in these teeth, both occlusally and facially, we can see that the insertion is really easy. So preparing is not needed at all. Of course, the case was a little bit more complicated. The previous bridge was a disaster. She had recession on the bridge, so somebody decided to cover that recession with composite resin. And if you ever have this idea, just check this out. This doesn't work. And the veneers were easy. I didn't need to prep, almost nothing. I just rounded just the incisal edges a little bit, not to have a sharp angle, and that was it. So I took care of the bridge, covered the recession, and then just do bonding on the, sorry for this Spanish text, this is bonding to intact enamel, and I just did bonding, and these were my veneers. I added ceramics and changed the bridge, and this was the final result. From here to here. But there's no real big work here. I'm not better because I didn't prep. I just realized that I didn't need to prep. Because most prepless veneers are partial veneers. Here sometimes we have easy situations to cover totally. Sometimes we cannot do it, but we don't really need to do it. We don't need to cover the whole tooth, so we can do partial veneers. And this is the most common situation. Sometimes we still have lock, and we have teeth that are, of course I see here that there's just a fracture, but teeth are very, very easy here. We have very square, even rounded teeth, and we can just round the edges and have a very nice situation. Here I also had to take care of this asymmetry of the gingival synod of the image here in the right hand side. And I did a crown lengthening first. I used the mock-up, a previous mock-up that I put on the teeth, remove the excess of gingiva, do a little bit of bone recontouring, and then close it and leave it like that. This has been published in the International Journal of Aesthetic Dentistry. And then once everything is healed, I just wanted to make sure that I had enough space for almost no prepping. So I used the calibrated disc burr just to make sure that with my mock-up I had more than enough space. So once I was done, I removed the mock-up, I checked it up, and I just needed to round up all these sharp edges, and this is my preparation, which means I almost did not do any preparation. And my dear friend August Bruguera made these fantastic 4 veneers, and I bonded them. When you bond prepless veneers, there's a problem, and I always bond with clamps and isolation, complete isolation, but you don't really know where to place the clamp. So you have to check every time if the clamp is in a good position. Place the veneer, bond it, then take care of the edge of the restoration and flatten it, just because we don't want to have any kind of little overhang. And once we're done, just remove everything, wait for 2 weeks, and we have nice gingiva and a very nice result. Again, these teeth allowed me not to prepare teeth. It's just that easy. I realized that I had a good situation not to prepare it, but I'm not better just by not prepping. It's just that I had this luck, just that. So this is the before and the after, and we can see that almost not prepping, just by a good planning, we can have a very nice result. How do I prep? Well, basically, there are 3 preparation designs. We have what we could call the incisal butt joint, the no incisal preparation, the no incisal reduction, which is in the middle, and the palatal chamfer. And well, for me, the best is the incisal butt joint, because it is easy to prepare. We allow the technician to have space to reproduce the incisal effects, and it is very resistant. If you check the literature, it is the best preparation design in terms of resistance. The second one is, I always have doubts with it. It is resistant, almost, or sometimes even as good as the first one. Is very resistant. It is very easy to prepare again, but it doesn't allow the technician to reproduce the incisal effects. And if you have a very flat tooth, what can happen is that when you're gonna bond the restoration, you don't exactly know where the restoration ends. And this can be a problem. So for me, it's so design. For example, the first one is very easy. You can check the butt joint and you can check the position very easily. So for me, in terms of lab work and cementation and bonding, it's better, the first one. The one that you have to forget about it and stop doing it is the palatal chamfer. Don't do this. Don't ever do this. Because what happens all the time with this kind of preparation is that, first, yes, it allows the technician to reproduce the incisal effects. But it is hard to prepare because making a very small chamfer in the palatal area is complicated. Second, is fragile. It usually breaks. It's the worst design as shown in the literature. And once you have a palatal preparation, the insertion is, of course, it has to be done from the incisal aspect. You have to go directly from the incisal aspect. So it has more relation with a crown than with a veneer. So your preparation has to be explosive. And by having an explosive preparation, you will have to prepare much more sound tooth structure just because you have gone to the palatal aspect. So don't do this. There are a lot of articles. I just quote these two by the group of John Coyce, Smith, Phillips, and also this article by Petra Gus and Christian Stappert. And in both cases, they show that palatal chamfer has problems while butt joint is better, or even the non-reduction, non-incisal reduction is better. So there's also another article by the group of Coyce, and they say exactly the same by Jacopo Castelnuovo, and they always say that butt joint is the easiest and the most the best preparation design. Okay, now I know which is going to be the shape of the preparation, but how much enamel do we have to prepare? Because if we talk about veneers, we want to keep them in enamel. And well, if we see what the literature says, the enamel in the upper anterior teeth has more or less these measurements in terms of width, and we have 0.4, 0.9 in the middle, and in the incisal area we have 1.2 millimeters, more or less. This is according to Professor Ferrari. And if we see this, maximum enamel reduction could be 0.3, 0.6, 0.8, more or less in the middle. And this is not for the in terms of width, but in terms of height. I usually do a reduction of 1.5 to 2 related to the mock-up. This is not related to the size of the actual tooth. And since we're doing a lot of times additive wax-ups, sometimes I almost don't need to do any incisal reduction of the tooth. I'm just talking about the mock-up. This is the space that I want for the veneer in the incisal edge. This is a very classic article by Professor Ferrari. And, well, the article by Ferrari had not a lot of teeth. And I was worried because most of the literature says that patients lose enamel over time. And this is something that we already know. And I wanted to know what happens with the patients that we treat the most. And maybe some guys, even in this International Aesthetic Master Congress, they treat a lot of, let's say, 20-year-old models. But my patients are regular people, and they are usually aged between 40 and 50 years old. And I checked this very good article by Atsu when they realized that patients over 50, had much less enamel. As you can see, 1 millimeter over the CJ, they had 0.17 millimeters. 3 millimeters, it was 0.32. 5 millimeters over the CJ, the patients had 0.45 millimeters, and this is very little. 0.17 is paper thin. So if you're going to prepare a tooth on a patient over 50, you're going to expose enamel. Sorry, you're going to expose dentin. So we have to have this in mind. If somebody tells you that all their veneers are always in enamel, either they are not prepping in the cervical aspect, which is fine if you can do it, if you have a good substrate, or if they prep, they are gonna be indenting. Maybe they don't see it, but they're gonna be indenting. And this is the article by Atsu. This is a Turkish paper, which is very well prepared. The materials and methods were fantastic. So just imagine that you have a complex situation like this. Diastemata and recessions over, even though we had some root coverage procedures done, we still had some recessions. And we had to close all these spaces, very triangular shaped teeth, and we had to prep a lot. And maybe now I would have prepped much less, but this was a few years ago, and I was more concerned about insertion path and making it one-shot case. Don't try to be more and more conservative. And we had all this bonded, and this case was done a few years ago, 2011, and everything is still in place, and all the spaces are closed and everything is fine, but preparation was just too much, and there was a lot of dentin exposed here. The way we usually prepare is we mark with our calibrated disc burrs, we remove the mock-up, then we finish it up, we place our cords, and then we check if we leave enough space with matrices, with silicone indexes. And this has been many times published. The first articles were by Galip Gurel and Pascal Magne and Urs Welser. And it's been done over the years, and it really works. So if you don't have enough experience, this is the way you should do it. And even if you have it, in order not to commit mistakes, this is the easiest way to be predictable. So now let's go to my usual patients, let's say, because I usually treat patients that have problems. And if you check this smile, you would say that, well, you have flattened teeth with no dominance of the centrals, but we have more than this. We had recessions, tetracycline staining that was not very visible because this patient had a lot of whitening treatments done over the years. But at one point, she decided that she wanted veneers. And she wanted veneers in the upper segment and in the two lower central incisors. So this is the initial situation. I wanted her to have root coverage procedures, which she rejected. And I said, well, what I have is a bad situation. I have exposed dentin, not doing anything, and I have not the best substrate. So I have to prepare these teeth. This is the pre-op again. And what happens when we have almost no enamel and exposed dentin? Well, every time we have these situations, we have to be, as you can see here now with the image that is more contrasted, we have to do immediate dentin sealing. We have to extreme our care with the margin and use carbide burrs. What do I mean by extreme care? Well, once you have dentin exposed, just look for an insertion path. If you have a small insertion path, that's gonna be it. Don't prep more. Try to be as conservative as possible. And using carbide burrs is better than using diamond burrs. The cut is cleaner, and the surface is gonna be better for bonding over later on. And then I use immediate dentin sealing. Of course, it has to be used every time you expose a big portion of dentin. Use a 3-step etch and rinse DVC system. After etching not more than 15 seconds, I try to do 12 seconds more or less. Then we use the primer and the bonding, light cure, and eliminate the inhibited layer not to interfere with the impression material. It is important to polish the bonding material, to polish it a little bit, because if you use, for example, Optibond FL, it is quite thick and it will leave some edges. So we want to polish it with the softest polisher, very, very gently, but just to remove a little bit those small edges. And well, this is just 12 seconds of etching, then primer, bonding, and as you can see, you can extend it with a probe. This is directly taken from Professor Magni. And it is important to realize that exposed indenting is not a problem if we have enamel in the periphery. So having enamel in the periphery will allow a long-lasting adhesion. This is something that we know from conservative dentistry, from class 2 restorations, etc. And Gallic Girl made an article where he was saying if he had dentin in the margins, either because there was already exposed dentin or because they did some crown lengthening procedures, when they were having margins in dentin, the failure rate was increasing tenfold. They went from 3% failure rate to almost 30% failure rate, and this is worrying. So be very, very gentle when you are going to expose dentin, and realize that it may fail over time. So you have to tell your patients this is a complex situation, and maybe this restoration is not gonna be it's not gonna last forever. So, for example, a good situation when we have exposed dentin is something like this. Yeah, I'm gonna change a little bit the image. Just check this up. Now we have exposed dentin, yes, of course, but the margins of the restoration are in enamel. Just, you can see the outline of the restoration, where the restoration is going to be bonded. And you see that we have dentin here and dentin here. But all the rest is enamel. So we're going to be fine. We don't have dentin in the margins, especially in the gingival margin, which is what worries me the most. And it's going to be a good situation for a ceramic veneer. In the previous case, as you can see, I almost didn't make a big chamfer or a big margin. I just did the minimum, and I kept as much enamel as possible. I had my quartz placed for the impression, and this is right after bonding. If you remember, the patient had recessions in all the teeth, in all the anterior teeth, and those recessions were really dark. And this is 2 weeks after bonding, and the patient asked us, "Hey, what happens here? What happens here in the interproximal of number? If we are in Europe, is number 22, the left lateral incisor." And you always say, well, it's gonna be better over time, and you go directly to I don't know, to pray somewhere, because you want this to be better right away. So you have to be comfortable. If you have done a good bonding and you have taken care of your margins over a few months, this will improve. And you can see here now that the situation has improved dramatically. Now there's almost no dentin exposed. You can see from the sides that the restorations have been much better now over the months. And you can see good integration of the restorations. Are these restorations going to last forever? Well, if we see what the literature says, bonding on dentin is not 100% reliable. But if you take care of the technique, now that we're seeing the papers by the group of Merbeck, the results with some bonding agents like Optimum FL or Clarifil SE are fantastic over now I think it's 13 or 15 years. So I can be quite safe over this period of time if I had done a good bonding technique. Well, this is a very common question. What do we do with the all composite resins? And well, the easy answer is that if you haven't placed them, just remove them. This is something that is like the rule of thumb in almost every practice, but we don't really do this. Some cases like this is what is going to happen. This patient has 2 composite resin restorations, and the lateral incisor was a little broken, and he only wanted to have these 2-3 teeth treated. So we had to take very good pictures of the other lateral, which was going to be the tooth that we wanted to copy. Since my technician is not in the same city as I am in Bilbao and he is in Barcelona, this is like 600 kilometers far away. I had to do very good pictures, and I took many good images of this tooth. For example, using Polarize, you have this kind of color X-ray of the tooth. We send this info to the technician, and then we prep the teeth. And after removing the composite, which was not in the best shape, we saw a good substrate where the biggest composite restoration was, which is this one, and we did a 0.5 margin for a laminate and removed all the composite resin. The other central incisor was darker and we needed more space, so what we did is a 0.8 to 1 millimeter laminate after removing all the composite resin, and we had a lot of interproximal composite resin, but we needed a lot of space, so leaving it was a problem. The lateral incisor was a tooth that was had some malposition, so we had to correct that position, which is like immediate orthodontics. This is not the best treatment. The best treatment is always orthodontics, but since we had a fracture, a small fracture, and the patient only had this tooth with a malpositioning, we decided to just prepare the veneer. It was a very thin veneer, correcting the angle. And well, the technician made 3 veneers, and this is the result. We had a pretty decent result, copying the shade of the intact lateral incisor and having, with different thicknesses, the same color in all the restorations. And I really had to say that, wow, Auguste had a great day that day. Let's see another case. This is a case where these teeth had composite over composite over composite. And in this case, removing all the composites is not going to be possible. The good thing is that this patient had big erosion and wear in this anterior teeth. So if you see this wear pattern, you see that she's putting her lower teeth a little forward, but we checked that if we had some space, and with provisional restorations we realized that we had some space to put her teeth backwards. So here what we have now is that we want to change this all almost all composite restorations, all composite crowns sometimes, into all ceramic restorations, and we prepped the teeth and kept almost all the composite resin. I don't change all the composite resins that I find in preparations. Usually what happens is that if they are poorly done, composite resin restorations, these restorations, what happens is that they just pop off. They just jump out of the mouth. But if they are still in place and nothing happens with them, we can keep them. They are probably done by a good dentist in the area, or even yourself. And why changing them? So I just do my initial preparation, place my triple O cord, then we have some retraction, and then we just can polish or flatten the restoration, the preparation. This is a very good burr to do it, the carbide burr for crown preparation. This is actually, I want to thank Yunino from Japan from telling me about this burr, because I found it really, really useful. So thanks, Yunino. And as you can see, I kept a lot of composite. I didn't remove everything. I just kept composite in all the incisors and one of the canines, and we had no problem. They were going to be covered by ceramics. So we have 4 situations more or less where I really have doubts. And this is just what I do. I haven't seen any literature regarding this. But if I'm preparing veneers and we have class 3 restorations, class 3 restorations can be in these situations. They can be in the palatal aspect. They can be in the whole interproximal area. They can be a little bit more in the facial aspect, or they can be in the facial aspect and go a little bit more to the interproximal area. In these 3 situations, I prep differently. In the first one, I try to avoid them if that is possible. If I don't need to go to interproximal a lot, I try to avoid the composite resin. In the second situation, I have no chance, and I leave it in the middle. The preparation is the same, and I have to accept that I'm going to have composite. So when I have to bond over that composite, I will have to treat it differently to the rest of the tooth. If I have the third situation, I try to cover it totally. Just because I don't want to leave a very, very tiny piece of composite resin that is going to be an extra interface in my restoration. So I try to remove it totally with my burr, or put it under my future restoration. And if I have the fourth situation, I have two choices. One is to do the same as the second. And 2 is, if that is possible, covering it totally and leave it almost on the edge. Is this the best? No, it is not. But I have to have 2 situations, either the second or the fourth. And if I need to, I will cover it totally. But this means that if you cover it totally, you will be preparing more sound structure. So you have to be very careful the tooth you are going to prepare. Maybe you have to accept the situation and just leave one more interface. So in this case, what we did is 1 veneer and 5 jacket crowns, 5 feldspathic jacket crowns. There's no coping here, and which is just bonded them, covering all the composite resin. This is the final case. This is the way it was finished. And well, this is the occlusal view. And sorry I don't have the occlusal marks, but she's fine now, and this case has had, I think it's been working for the last 4 years. Well, this is a very important part. If you're going to do ceramics over composite resin, you have to realize that you have to prepare the surface of this composite. And there's a few articles by Marco Kresnik talking about this topic, and he says that bonding on aged composite restoration works just as well as bonding on new composite restorations. And we only have to do surface conditioning to have a good result. Well, finally, where do we place the margin? We have addressed the space, different substrates. We have addressed the insertion path, and now we want to know where do we place the margin. Just imagine this case. This is not a good situation. This is bad substrate. We have diastemata or black triangles also. We have composite. We have all sorts of problems. And if we check the lower, it doesn't get any better. And we also have small recessions. So we'll have almost everything here. Always keep in mind this. The more we prepare, the darker it gets. The good thing with lower teeth is that they are not as dark in the apical third, so we can survive. In the upper, she shows everything, and checking this is very important. How much the patient smiles, and always remember that these patients usually don't smile, so they have no tone in their lips, so they smile very little, and they will end up smiling more. If they show almost all the tooth, you will have a patient that smiles later, showing all the tooth totally. So what do I do? Well, if I have limited enamel and small recessions and doesn't show the lower teeth, which is very important, I look for supragingival preparations. As you can see here, I go over the gingival margin and I try to avoid go deeper where I'm not going to have any enamel and I'm going to be in a recession. And anyway, she doesn't show that area. So you always have to tell the patient, hey, here you will have to have some roots appearing there. You will show them, but we want these resolutions to last forever, if that is possible. We never know, of course. In the upper area, in the upper teeth, we had enough enamel, we had no recessions, and she showed the diastemata or black triangles. So we have to, if we want to close them, we want to go subgingival. I always use this instrument as a retractor. It's not actually a gingival retractor, it's just a composite resin instrument, the cheapest one you can find in your drawer, and you just use it for moving this gingiva to end up preparing the tooth. So you retract the gingiva, you end up your preparation a little bit subgingival, and this is the way I think is in terms of my margin. If I have diastemata and I want to close it, I have to go subgingival. It's either the margin in the tooth or the margin of the restoration. If you remember the case where we had spacing and fractured teeth, and we almost didn't prep, it was the restoration margin, the one that was subgingival, because I didn't prep the tooth. There was no margin on the tooth. If I have recessions not treated or not treatable, for example, Miller class 3, class 4, I have to think about this. If it is visible, maybe I have to accept it and go subgingival, because the patients come to your office for aesthetics. If it is not visible, you don't care. If the patient doesn't show it, you don't want to put in danger your restoration just for going subgingival and not showing it. It is nonsense. So this is my preparation. As you can see in the laterals, I left composite resin. She had extensive composite resin restorations in those teeth. And you can see how dark the canines are and how dark, even though I kept some enamel, the centrals are. So I gave a lot of space to the technician, and he made thick restorations. Thick restorations for a very dark substrate. And this is important. You cannot cover a tetracycline stain. You cannot mask it unless you give space. You will go towards the tooth and towards like outside with this thickness, but still you have to prep the tooth very well. In order to close the space, the technician prepares the model properly and checks the contacts. And this is important. Every time you have a spacing or a black triangle and you prepare veneers and you go just subgingival, you won't close it unless you do a very square veneer right in the middle, which is not going to be anatomical at all. You're not going to close it. It's going to be very tough to close it because the papilla is flat, and unless the contact goes really low and have less than 5 millimeters under, less than 5 millimeters towards the bony crest, you won't have a closing of that papilla. In order to change it, what you have to do is go a little bit subgingival and change the emergence profile of the tooth. By doing so, what you'll do is to push the gingiva a little bit with the veneers, and you will have a closed papilla. Very important, if you see in the profile, is doing it like in the third image. Go all the way to the top of the papilla. If you close the papilla with a veneer that doesn't go to the tip of the papilla, like in the second image, what you will have is a false closing. And you will have food entrapment and inflammation behind the veneers, and that is a problem. Just take care of the periodontium. When you're changing the profile of the tooth, you are taking some risks if you don't take care about the periodontium. The periodontium will make your restorations look good. It is not just the ceramics. It's gonna be the gingiva, let's say the referee that will say that your veneers and your case is good or not. So when you try them, you can see that there's no closing still, but we only need time because we have told the technician, hey, place this contact X millimeters, let's say 1.5 millimeters over the preparation, and we will have a pupilla. And just by waiting 2 weeks after bonding, we can have this. So yes, we still have a very tiny black triangle in between the central and the lateral, but the lateral and the canine was totally closed after 2 weeks, and everything is fine now. This is just after 2 weeks. And patients that don't smile that much, after a few weeks, are just happy. You can see the dark substrate here. You can see how much we have masked, both in the upper and the lower. On the lower, when I do these kind of veneers, I usually end up doing almost veneer overlays, covering all the occlusal and the facial aspect of the teeth. In the upper, sometimes I need to, sometimes I don't, but the principles are pretty much the same. So masking a dark substrate needs thickness. This is very important. If you have cases with dark, really dark substrates, it is the same as with crowns. You need space, but you don't need to do crowns. Just by doing veneers that are opaque or with opaque dentin, it can work just as well or even better, because we are much more conservative than a crown. There's another way of opaquing it. Well, you can use either opaquer or Emax to control the substrate. But if you use opaquer, it is much thinner. It masks much more within less space. Emax needs always more space. If you use Emax MO or HO, you may need up to 0.6 or 0.8 to really mask a really dark substrate. So you have to bear this in mind. And of course, take care of your margin. If you go let's say over the CJ, with the first preparation, which is, let's say, a regular preparation, you will be okay. With a no preparation, you will be even better. But always think that we want some thickness of the ceramic, if possible. And with a very thick preparation, with a very thick restoration, we have to be careful and always leave some enamel in the cervical aspect, because that will keep you safe. But if you go a little lower, you will have more problems. Maybe not with the first two, especially with the second preparation design, but with the third, you're going to be really indenting, and that can be a problem. Just to summarize, we have to think about preparation and restoration margin. If you have a favorable shade or limited enamel or both, we want to do a contact lens. We want to do a restoration that is going to take the color from the substrate, which is favorable. So we can go prepless or with 0.3 preparation. Just maybe the shape of the preparation is not ideal, so you may need to prepare the tooth. On the other hand, if it is unfavorable, you want the self-colored veneer. You want a veneer that doesn't depend on the substrate. The preparation will be thicker, and then it will be over-contoured. If we have diastemas, we have to go subgingival if we want to close them. And we have recessions, just as I said before. If it is visible, you will have to go subgingival. And if it is non-visible, you will you may prefer to go super gingival. So now I want to talk about a little bit about the burrs. I made a small preparation burr kit. These burrs are the 7 steps that I do in every veneer case. I usually use this round burr for the gingival margin, then the 3D calibrated burr, the thin one for the gingival third, and then the medium one from the medium and incisal third. Then I use a medium grit diamond burr, and then a fine grit diamond burr to smooth the lines. And then I polish the preparation with the carbide burr, and I also use discs to polish the preparation and to round the angles. So if you want to see it in pictures, what I do first is my gingival margin with the round burr. I always try to contact with the burr with the surface of the tooth, not to be deeper than the sphere of the burr. Then I use the calibrated disc burrs, different calibrated discs to go thicker as I go incisally. And then I use a medium to thick grit burr and a thin grit burr. And finally I polish the preparation. And then we round the angles of the preparation with a disc. And we try to eliminate all these thin enamel areas to make a much softer preparation. If we see it in a tooth, we do exactly the same. We use the round burr first. Then we can mark the incisal edge reduction, but this is, I hate this. I can tell you I hate this, because every time you go then to eliminate this, you end up doing something like this, and then it takes longer. So just don't do it. It is a pain in the ass, actually. Then I use the 3D calibrated burr, and this is important. We every time we use these burrs, they have a lot of torque. There is a lot of resistance when they cut, and we try to avoid going beyond the line angles, because if we go beyond the line angles and we lose contact, what will happen is that we're doing like zzz, and suddenly we jump to the next tooth and touch it. If you want to prep just one veneer, for example, like in this case, you don't want to touch any other tooth. So try to avoid going beyond the line angles. Then you smoothen this surface using burrs. For the interproximals, we can use the ultrasonic tips with our only working on one side, or metal strips, for example, like these ones by GC. And yes, I like to break the contact points. This is something that a lot of people ask me. I prefer to do it because sometimes, for example, we have tooth malposition and we want to change this, and only breaking the contact points is possible. But sometimes I just do it because when I do the impression, if I don't break the contact point, what usually happens is that I press my impression, and when I remove it, I always have the light silicone in that space. So if you break a little bit this, you won't have that problem. Well, finally, I reshape a little bit my margin. I take care of the margin and all the surface with the carpet burr, and use the discs. Discs are really, really, really important. As you can see, I didn't have a flat surface of the incisal part of the preparation until I used the disc. And very important, rounding angles, as I said. It is important not just because sharp edges are bad for ceramics, which is easily said, but for a much more practical thing. Just imagine that you have prepared the tooth and you left this sharp edge in the incisal area. What will happen when you prep the tooth this way is that then you go to the lab, you have taken a very good impression with a fantastic material, and you go to the lab and the lab uses the best stone and they still have this. But if the technician is using, for example, a refractory material, the refractory material is more dense, and the surface energy is different, and it won't feel everything. The problem is that we will have something lacking, some detail lacking in the refractory die. And this is the problem. Now the technician uses the refractory die and places ceramics over it and makes a very nice veneer. Now what happens? Well, the technician maybe didn't check that much the veneer in the model and sends it to you. And you have this. Now what happens? Well, you can either go like this, and it fits in one side and it doesn't fit in the other, or you can go like this, and then you just cut a little bit of the palatal aspect and bond it, and it will break. Or when you press a little bit more than what you should, it breaks during cementation. So sometimes it is not a problem of the lab work. It is a problem of the work done just maybe 10 days, 15 days ago when you had to prepare and you didn't check this. And this is again and again and again and again and again. You see here that I placed the triple O cord, and suddenly I have more retraction and I can finish up my preparation and the metal strips and using the disc. And this is done all the time that we prep veneers. And if you do it all the time the same, you will be predictable. Your preparations will be very, very similar one to the other. So if we think about tooth shape, in order to calculate the prosthetic space and think about your margin situation, you have a preparation. I want to thank you all for spending some time with me. And this is my email. So if you want to make some questions or ask me for any burr or whatever, I will answer you. Usually it takes me time to answer. Don't get me wrong. I try to answer everything, but sometimes I'm not that fast. So if I didn't answer, it's just that I forgot it, and you can email me again. I will answer you right away. And I want to thank Jon Gurrea for organizing this fantastic Congress. This is something new, something I have never done. And I hope that you will enjoy the rest of the Congress. Thank you very much.